Imagine surviving, like a really grueling organ transplant, or, enduring this massive stem cell procedure, or even overcoming something as severe as an ovarian tumor.
Right. Yeah.
For most people, that moment feels like the ultimate finish line, right? Like you get the surgery, you ring the bell in the hospital, and you just assume it's time to go back to your normal life.
Yeah, and honestly, the clinical focus is almost entirely on just getting you through that acute crisis. I mean, the initial survival is treated as the climax of the story,
Exactly.
which kind of leaves the aftermath largely unmapped for the patient.
But for millions of patients, that supposed finish line is actually, it's really the starting gun for a completely different kind of marathon.
Yeah.
And we're talking about the lifelong reality of taking systemic immunosuppressants.
It's a huge shift.
It is. So, welcome to the deep dive. Today's mission is tailored specifically for you, the curious learner who really wants to understand the long-term use of systemic immunosuppressants following a major medical intervention.
And we've got a lot of ground to cover.
Oh, yeah.
Yeah.
We have curated this massive stack of medical literature covering like everything from transplant pharmacology and ovarian germ cell tumors to Sjogren's syndrome and even benign vulvar disorders.
It's a really wide range.
It is, but we're taking all of this to answer one underlying question, really. What actually happens to a person's reproductive health, their fertility, and just, their overall quality of life when they have to continuously suppress their own immune system for decades?
It's just a phenomenal area of medicine, honestly, because it forces us to look at the collateral impact of these life-saving therapies. When you alter the body's foundational defense mechanisms, you inevitably shift how every single other biological system operates on a day-to-day basis.
Right, and to really grasp that lifestyle impact, I feel like we need to establish the baseline of what these drugs are physically doing inside the body.
Yeah, let's break that down.
So I tend to picture the immune system as this like hyperactive neighborhood watch.
Right.
Like they're highly dedicated to keeping the body safe, but they are incredibly aggressive.
Extremely aggressive.
So if a new neighbor moves in, like say a transplanted kidney, the watch immediately flags that tissue as a foreign threat, and they just mobilize to kick it out.
Exactly. And that's where calcineurin inhibitors come in. They're a major class of these drugs. So think of medications like cyclosporine and tacrolimus.
Okay.
They basically step in to disrupt that mobilization. And we also rely on antimetabolites like mycophenolate mofil, which we usually just call MMF, and azathioprine.
Right, and steroids too, right?
Yeah, heavy-hitting corticosteroids like prednisone. And the thing is, these aren't just generic dampeners. They specifically target T cells and B cells.
And those T cells and B cells, I mean, they're basically the primary drivers of the immune response.
They are. They're the specific cells identifying the foreign tissue and coordinating the attack. So the immunosuppressants work by basically halting the cellular proliferation of these cells.
Okay, so stopping them from multiplying.
Right. They interrupt the synthesis of DNA within the T cells, or they block the release of cytokines. And cytokines are, those chemical signaling proteins that trigger inflammation and recruit other immune cells to the site.
Right, so by shutting down that cytokine signaling, the drugs essentially take away the neighborhood watch's walkie-talkies.
That's exactly it. No walkie-talkies, no coordinated attack.
Which is great, because it stops the attack on the transplanted organ.
Yeah.
But now the entire neighborhood is left completely vulnerable to actual burglars, right? Like bacterial and viral infection.
Yeah, the door is wide open.
And sometimes the threat isn't just the host's body attacking the new organ. Like, I was reading the literature on stem cell transplants, and the dynamic completely flips.
Oh, yeah. That's a whole different ballgame.
Yeah.
Following an allogeneic stem cell transplant, the patient's original immune system is wiped out, and they take on the immune system of the donor.
Wow.
Yeah, and that new immune system begins circulating and frequently recognizes the recipient's entire body as foreign territory.
That's terrifying.
It triggers graft versus host disease, or GVHD. Now, acute GVHD typically attacks the skin, the GI tract, and the liver. But chronic GVHD, that operates much more like a multi-system autoimmune disorder.
So basically, the new neighborhood watch starts attacking the original houses.
Exactly. And chronic GVHD brings severe long-term implications, frequently involving mucosal tissues, including the genitals, which we'll dig into a bit later.
Yeah, we definitely will.
But the management of this requires sustained systemic immunosuppression.
I find myself just getting stuck on the underlying logic of this whole approach,
Yeah.
Like, we are intentionally disabling the body's primary defense system by stopping DNA synthesis in T cells and just leaving the door wide open for systemic infections.
Yeah, it sounds crazy on paper.
It does. Maintaining this state for decades just seems incredibly dangerous. How do clinicians justify that sustained risk?
Well, clinicians basically operate within what is known as the therapeutic window. It's this razor-thin pharmacological margin between stopping the immune system from, say, destroying a transplanted liver and pushing the patient into toxic side effects or a lethal opportunistic infection.
So it's a really delicate balance.
Extremely delicate. And the justification is purely survival. The alternative to the immunosuppressant is organ failure or unchecked autoimmune destruction, both of which are immediately life-threatening.
Right.
So the clinical challenge is finding the absolute minimum trough level of the drug required to maintain that graft tolerance.
Got it. And once that tolerance is achieved and the patient finally gets past that acute recovery phase, their thoughts naturally turn toward building a future.
Of course.
And for younger patients, the immediate question is usually whether they can still have biological children. I mean, you would assume someone with a transplanted organ and a suppressed immune system would be completely out of the running for family planning.
You'd think so, but the clinical data actually presents a massive reproductive paradox. In the context of female fertility, patients suffering from chronic kidney or liver disease almost universally experience severe fertility disorders prior to the transplant.
Oh, really?
Prior to it.
Yeah, end-stage organ failure creates this highly toxic internal environment that severely disrupts the hypothalamic-pituitary-gonadal axis.
So the endocrine system just totally shuts down.
Exactly.
But looking at the sources, it shows that fertility can bounce back astonishingly fast post-transplant. Like, normal ovulatory cycles can return in as little as 1 month after a successful surgery.
It's wild, isn't it? Clearing those systemic toxins, like uremia, it allows the reproductive hormone signaling to reboot almost immediately. The HPG axis basically recognizes that the physiological state of emergency has passed.
That's incredible.
But the return of ovulation doesn't mean a return to baseline fertility. These patients face a really high statistical risk of premature ovarian failure, entering menopause an average of 4.5 years earlier than the general population. Man, losing 4.5 years of reproductive viability is a massive blow if you're trying to plan a family. Is that accelerated timeline a direct result of the anti-rejection drugs?
That's the surprising part. It's actually a consequence of the physiological damage sustained prior to the transplant.
Oh, wow.
Yeah, the prolonged oxidative stress from the organ failure itself, combined with the intense pre-transplant therapies, permanently diminishes the ovarian reserve. So it's not the current immunosuppressants causing the early menopause, but rather the biological debt accrued during the disease state.
That makes a lot of sense.
Yeah.
We also look closely at malignant ovarian germ cell tumors, or MOGCTs.
Right.
These are aggressive ovarian cancers primarily affecting women in their teens and 20s. Now, an ovarian cancer diagnosis sounds like an absolute end to fertility.
It does, but MOGCTs are highly responsive to chemotherapy, and modern oncological protocols utilize fertility-preserving conservative surgery.
What does that involve?
It involves removing only the affected ovary while intentionally sparing the uterus and the contralateral healthy ovary. The long-term follow-up studies on this are just remarkable. Between 87 and 100% of women regain normal ovulatory function and fertility within a year of completing their chemotherapy regimens.
That's amazing. And that endocrine reboot isn't just limited to estrogen in the ovaries either. The male reproductive system is just as sensitive to systemic toxins.
Oh, absolutely.
In men with end-stage renal disease, uremia heavily suppresses testosterone production, leading to severe hypogonadism.
And then, following a successful kidney transplant, approximately 50% of men see a complete reversal of that hypogonadism within the first year.
So it bounces back too.
Yeah, the testosterone levels recover as the blood is properly filtered. But this is where the specific classes of immunosuppressants introduce major complications for male fertility.
Right, so the drugs themselves act as the barrier here?
Exactly. The medication sirolimus is highly associated with male infertility. It operates by inhibiting the mTOR pathway, which regulates cell growth. Unfortunately, That pathway is absolutely essential for normal spermatogenesis. Studies indicate that men taking sirolimus experience significantly reduced sperm count and motility. We're talking a 15-fold lower fathered pregnancy rate compared to those on different immunosuppressive regimens.
A 15-fold drop. That is huge.
It's massive, and high-dose cyclosporine regimens are also clinically shown to heavily compromise sperm motility.
So it's basically like the body acting as a city in crisis mode. When the liver or kidneys are failing, the city diverts all available power away from the public parks, which in this case represents reproduction, and sends it straight to the hospitals just to keep the infrastructure from collapsing.
Exactly. It's a complete diversion of metabolic resources.
Then the transplant happens, the anti-rejection drugs establish peace, and the power grid stabilizes. The parks reopen, often within a month.
Right.
But now the city has to deal with the maintenance crews, the immunosuppressants, who are keeping the peace but actively trampling the grass and tearing up the pathways, specifically with drugs like sirolimus.
That's a great way to picture it.
And because those parks reopen so incredibly fast, it creates an immediate, dangerous complication.
It really does, because getting pregnant within the first year post-transplant carries severe risks for both the mother and the graft.
Right.
The immune system is highly volatile, the drug doses are at their absolute highest to prevent acute rejection, and the hemodynamic stress of pregnancy can easily trigger graft failure. So, highly effective contraception is basically medically non-negotiable at that point.
And here is where the statistics get really alarming. The baseline rate of unplanned pregnancies in the United States hovers around 50%.
Which is terrifying in this context.
Seriously, flipping a coin on an unplanned pregnancy when your new kidney is still stabilizing is a terrifying prospect. Which brings us to this massive historical medical myth regarding contraception and immunosuppressants.
Yeah, this one is wild. For a very long time, clinical practice guidelines actually discouraged transplant patients from using intrauterine devices, or IUDs, based on a fundamental misunderstanding of cellular mechanisms.
And the logic seemed sound on the surface, I guess. Doctors understood that copper IUDs prevent pregnancy by creating a localized inflammatory reaction in the lining of the uterus, right?
Yep.
Creating a cytotoxic environment that destroys sperm and eggs.
Right, and so the assumption was that if a patient is on heavy systemic immunosuppressants specifically designed to blunt inflammation and suppress the immune response, those drugs would systemically cancel out the localized inflammation caused by the IUD.
They just assumed the IUD wouldn't work.
Exactly. Clinicians assumed the IUD would simply fail to prevent pregnancy.
They thought the anti-rejection meds were jamming the signal. I was so shocked to read how a fundamental misunderstanding of basic immunology kept the most reliable, reversible form of birth control away from this highly vulnerable patient population.
It's tragic, honestly. The paradigm finally shifted when researchers differentiated the cellular targets. Systemic immunosuppressants like tacrolimus and MMF primarily target the activation and proliferation of T cells and B cells, like we talked about earlier.
Right.
IUDs, however, do not rely on T cell pathways. The local cytotoxic environment created by an IUD is driven by the activation of macrophages.
Oh, macrophages being the cells responsible for phagocytosis-like engulfing and clearing out cellular debris and pathogens.
Exactly. And macrophage activation operates entirely independently of the specific T cell signaling pathways suppressed by anti-rejection medications. So even in a heavily immunosuppressed patient, the macrophages in the uterine lining respond to the IUD perfectly well. The contraception remains highly efficacious.
It's like assuming that because you jammed the radio signals, the landlines wouldn't work.
Yeah.
They just operate on two entirely different systems.
Exactly.
The literature also strongly advocates for the contraceptive patch and the vaginal ring over traditional oral birth control pills for these patients.
Yeah, and there's a very specific pharmacological reason for that. Oral contraceptives introduce a significant pharmacological risk.
Because of the liver, right.
Yes. When a pill is absorbed through the GI tract, it undergoes first-pass metabolism in the liver. The hormones can upregulate specific cytochrome P450 enzymes in the liver. And those happen to be the exact same enzymes responsible for clearing calcineurin inhibitors from the bloodstream.
Oh, wow. So taking the pill could cause the liver to process the anti-rejection drugs way too quickly, basically dropping the drug levels below that critical therapeutic window we talked about.
Exactly, which leaves the patient exposed to acute organ rejection.
That's so risky.
It is. But the vaginal ring and the transdermal patch absorb hormones directly into the systemic circulation, completely bypassing that hepatic first-pass metabolism. This keeps the anti-rejection drug levels stable and predictable.
Okay, so the medical team gets the patient safely past that crucial one-year mark. They utilize an IUD or a ring, and now the patient is actually ready to intentionally conceive.
Right.
But this transitions them into a highly complex teratogenic minefield. The very medications keeping their immune system at bay can cause catastrophic harm to a developing fetus.
Yeah, and this is where it gets incredibly delicate. Teratogenic drugs interfere directly with fetal development. Managing a pregnancy post-transplant requires meticulously choreographing the patient's pharmacology, starting with the absolute removal of mycophenolate mofetil, or MMF.
Because it's so dangerous, right?
Yes, the FDA classifies MMF as a Category D drug, meaning there is definitive evidence of human fetal risk.
And the data on MMF exposure during pregnancy is just harrowing. I mean, it is strongly linked to severe structural anomalies, particularly facial and auditory deformities like microtia and anotia, where the external ear fails to develop entirely.
It's devastating.
And it also heavily disrupts cardiovascular development.
Because of the drug's half-life and cellular persistence, clinical guidelines basically mandate that MMF must be completely discontinued at least 6 weeks prior to any attempt at conception.
But MMS is a foundational pillar of their anti-rejection protocol. How does the medical team handle that transition without triggering a massive immune response against the transplanted organ?
It's a heavily monitored process. It spans several months before conception is even attempted. The medical team slowly titrates the MMF dosage down while simultaneously introducing a substitute antimetabolite, most commonly as aethioprine.
Okay, so a swab.
Yeah, and the patient's graft function and serum creatinine levels are watched obsessively to ensure the azathioprine is maintaining immune tolerance before they ever give the green light for pregnancy.
But I noticed in the pharmacological data that azathioprine is technically also listed as an FDA Category D drug, which seems counterintuitive if we are using it as the safer alternative,
I know, it sounds confusing. The Category D label broadly applies to the drug's mechanisms, but decades of clinical data in transplant and autoimmune pregnancies demonstrate that the actual teratogenic risk of azathioprine in humans is minimal to small.
But how?
Well, the reason it is safe for the fetus comes down to a brilliant quirk of fetal enzymatic biology.
Right, this was the most fascinating mechanism in the entire stack of research.
Yeah.
I mean, please explain why the baby is protected from this toxic compound.
So, azathioprine is what we call a prodrug. When the mother takes it, it is not inherently toxic. Her liver utilizes specific enzymes to metabolize the azathioprine into its active immunosuppressive compound, 6-mercaptopurine.
Okay.
The fetal liver, however, is immature and fundamentally lacks the specific enzyme required to make that conversion.
That is wild. The fetus physically cannot process the drug into the dangerous compound. It's like the baby's liver doesn't possess the key to open the poison box, effectively shielding it from the toxicity.
It's a completely natural biological barrier.
Wow.
Now, the calcineurin inhibitors, cyclosporin and tacrolimus, they function differently. They do readily cross the placenta and enter the fetal circulation.
So they do pose a risk.
They do. While they aren't linked to the severe structural deformities caused by MMF, they do present risks of intrauterine growth restriction, low birth weight, and premature delivery. However, because they are so absolutely critical for graft survival, they're generally maintained throughout the pregnancy with just highly aggressive monitoring.
We also need to look at the unique maternal-fetal risks present in autoimmune diseases, particularly Sjogren's syndrome, where the threat isn't the pharmacology, but the patient's own autoantibodies.
Right. Patients with Sjogren's syndrome frequently test positive for specific autoantibodies identified as Rho and LA.
Rho and LA.
Yeah, and these are IgG antibodies, which are small enough to naturally cross the placenta as the maternal body attempts to provide passive immunity to the fetus.
But in this case, the mother is inadvertently passing pathogenic autoantibodies into the fetal bloodstream.
Exactly. In approximately 5% of these pregnancies, the maternal Rho and LA antibodies attack the developing fetal tissues, resulting in neonatal lupus.
Man, neonatal lupus sounds like a devastating lifelong diagnosis for a newborn.
It sounds awful, but fortunately it is usually a transient condition. The most common clinical presentation is a cutaneous rash on the infant.
Oh, just a rash.
Usually, yes. Because the baby's body is not actively producing these autoantibodies, the maternal antibodies eventually degrade and wash out of the infant's system entirely. The cutaneous lupus typically resolves completely within 17 weeks post-delivery.
Okay, that is a relief. So we've covered the acute survival of the transplant, the return of fertility, and the intense pharmacological choreography of pregnancy. But what does the reality of this immune suppression look like as these patients age?
Yeah, it takes a toll.
We really need to talk about the long-term systemic toll on the body's baseline infrastructure, starting with bone density.
This is huge. The rapid demineralization of bone is one of the most severe yet clinically underdiscussed consequences of long-term immunosuppression.
hmm
The loss of bone mass is profoundly intense in the first 6 to 12 months post-transplant.
And the data points specifically to the heavy reliance on glucocorticoids, like prednisone, during that initial post-op window. But how do steroids strip the bone so quickly?
Well, bone remodeling is a continuous cycle handled by two types of cells: osteoblasts, which build new bone, and osteoclasts, which resorb or break down old bone.
Okay, building and breaking down.
Exactly. High-dose glucocorticoids severely disrupt this balance. They actively suppress the osteoblasts while simultaneously upregulating the lifespan and activity of the osteoclasts.
Oh, no.
Yeah, so the bone is being dismantled much faster than it can be rebuilt, leading to rapid onset osteoporosis.
Which totally compounds the issue of premature menopause we established earlier. Because if a transplant patient enters menopause in their late 30s or early 40s, they lose the protective effects of estrogen, just as the steroids are driving osteoclast activity into overdrive.
It's a perfect storm. And this specific intersection of risks is exactly why hormone replacement therapy, or HRT, is a critical intervention.
But isn't there hesitation around that?
There has been lingering clinical hesitation about prescribing HRT to transplant recipients, sure, but the current consensus is clear. It is not contraindicated. In fact, providing exogenous estrogen is highly recommended to protect against both severe osteoporotic fractures and the elevated cardiovascular risks associated with early menopause.
That makes a lot of sense. Beyond the skeletal system, the literature highlighted a chronic condition that severely impacts quality of life, yet patients often suffer through it in total silence.
Mhm.
I want to look closely at chronic vulvar disorders and vaginal GVHD.
Yeah, this is a really tough one. Following a stem cell transplant, chronic graft versus host disease frequently targets the mucosal tissues of the genitals.
And what does that actually look like?
The inflammatory response leads to severe vaginal atrophy, intense burning, extreme mucosal fragility, and progressive scarring. In severe cases, the fibrotic tissue changes can link to complete vaginal closure, which fundamentally alters sexual function and anatomical integrity.
But reversing that fibrosis requires aggressive localized treatment.
It does. The protocols call for the use of vaginal dilators alongside ultra-potent topical steroid ointments or compounded tacrolimus suppositories applied directly to the mucosal tissue.
But the medical literature points to a massive structural roadblock in how these treatments are labeled by drug manufacturers.
It does, and it creates a severe barrier to patient compliance. The FDA package inserts for ultra-potent topical steroids explicitly state they are unsafe for use on genital tissues and mandate that usage must be strictly limited to 2 weeks.
Because they're worried about skin thinning.
Exactly. Skin thinning and systemic adrenal suppression.
But the clinical evidence for treating inflammatory dermatoses like GVHD or lichen sclerosus completely contradicts those package inserts.
Completely. The dermatological data is extremely clear. For these specific severe fibrotic conditions, long-term maintenance therapy with ultra-potent topical steroids is clinically proven to be highly efficacious and remarkably safe.
Really? Long term?
Yes. When used correctly on these altered tissues, it does not induce mucosal atrophy, nor does it suppress the hypothalamic pituitary adrenal axis. The treatment reverses the scarring and preserves the anatomy.
That's huge.
It is, but because the pharmaceutical labeling hasn't been updated to reflect the clinical consensus, patients read the insert, become terrified of the side effects, and abruptly stop using the one therapy that can actually halt the disease progression.
It's so frustrating. Applying an ultra-potent topical steroid to a localized GVHD flare-up is basically like taking a highly targeted fire extinguisher directly to a grease fire on the stove, right?
Right.
It puts out the fire exactly where it's burning without damaging the rest of the house. But the systemic oral immunosuppressants, we've been tracking this entire time, they operate entirely differently. Taking those pills is like turning on the emergency sprinkler system for the entire building.
That is the perfect analogy. And leaving that systemic sprinkler system running continuously creates a damp, compromised environment across the entire body. The global suppression of T cells doesn't just stop organ rejection, it also dismantles the body's natural surveillance system against rogue oncogenic cells and viral pathogens.
Which introduces the ultimate overarching complication of this lifelong marathon, the cancer paradox.
Exactly. Under normal circumstances, when a virus like human papillomavirus or HPV enters the body, the T cells recognize the viral proteins and clear the infection before it can integrate into the cellular DNA.
But in an immunosuppressed patient.
In an immunosuppressed patient, that T cell response is totally blunted. HPV thrives in this unprotected environment, establishing persistent infections.
Allowing the virus to induce cellular mutations over time.
Yes. This dynamic drastically increases the lifetime risk of developing HPV-driven malignancies, primarily cervical, anal, and specific forms of skin cancers. It necessitates a lifetime of hypervigilant cytological screening, far exceeding the guidelines for the general population.
The sheer balancing act required of a transplant recipient or a patient battling a severe autoimmune condition is truly staggering to map out.
It demands an unending physiological and pharmacological tightrope walk, constantly navigating the space between preserving the transplanted graft and mitigating severe systemic toxicities.
Through this deep dive, we've explored the astonishing resilience of the human endocrine system, watching fertility reboot in a matter of weeks. We've untangled the immunological mechanisms of macrophages to debunk the myth that kept IUDs away from vulnerable patients.
Such a vital shift in practice.
Right. And we navigated the terrifying transition away from teratogenic drugs like MMF, revealing how a fetal liver's lack of enzymes can literally shield a baby from toxicity. And of course, we unpacked the hidden systemic battles of osteoclast-driven bone loss, fibrotic GVHD, and the viral vulnerabilities of the cancer paradox.
The endurance required of these patients is profound, matched really only by the intricate precision of the medical science developed to keep them alive and functioning.
Absolutely. As we wrap up, I would leave you with one final thought to ponder. Medical science never stops iterating, and we are currently pushing the boundaries of regenerative medicine.
It's an exciting frontier.
It really is. Researchers are actively working toward a future where we can grow lab-made organs directly from a patient's own harvested stem cells. Imagine a scenario where a patient requires a new liver, and they receive a completely customized, genetically identical organ.
No foreign tissue.
Right. If the organ shares the exact same genetic footprint as the patient, it wouldn't trigger the neighborhood watch. We are looking at a potential future where the miraculous gift of a transplanted organ no longer requires the lifelong systemic suppression of the very immune system designed to protect you.
It would change everything.
It really would. The era of the immunosuppressive marathon may eventually become a thing of the past. But until that day arrives, the balancing act continues. Thanks for taking this deep dive with us.